the however many hundred people, and it seems to be quite high numbers of hundreds now, that either watch it streamed or on YouTube afterwards. Welcome to all of you as well. Those of you who are really observant will have noticed we've got a longer agenda than normal, and that's because as part of the way the board has been reviewing its way of working, we're looking to shift more of the items that we've traditionally, out of comfort, placed into private board. We're starting with the assumption that it should be public unless there's a really strong reason. So we're shifting a bit more stuff into this board, and we'll keep all of that under review. I very much hope, though, it doesn't change board behaviour in the sense that I hope we retain our reputation for strong, robust, but respectful challenge, whether we're in public or whether we're in private. This agenda, I'm hoping, is satisfactory. Can I check at the beginning whether there are any other businesses? I have one, which might last up to about 5 minutes, and it's to do with a departing member of the board. But apart from that, has anybody got any other items that they're going to want to highlight for us? And if that's the case, then we can just kick on our way. Can I just check with you? So we're getting in the people for item 1 from the beginning?
Yeah, we're just waiting on Terry.
That's it, okay, right. Well, we're going to get there soon. Apologies, who have we got, please?
Alistair Blair and Ross Wiggum.
Okay, just the 2. Declarations of interest as usual. I'm chair of Newcastle, but that's not new. Okay. Any other declarations of interest relevant? Minutes of the 30th of January, they seem not only accurate but pretty straightforward. Can I check for accuracy? Taking silence as assent, thank you. And I've got no matters arising. Has anybody else got matters arising that they wish to highlight for us? No? Okay, that's good. Then we're already on to the action log. And the action log is very satisfactorily green. So all the key actions are either appearing later on in this agenda or have already been identified or are not yet due. So there's nothing I wish to raise from the action log either. Are we all okay? Anybody else got something they wish to raise? We're motoring through these first formalities. Thank you for your collaboration on that. Item 1.4 is my chair's introduction, and all I really wanted to point out is we are in exciting times at present for the NHS. NHS in some considerable turmoil, or certainly rates of change nationally, and I guess the point that we're all coming to recognise is it's not directly affecting us in the sense that what might be read as turmoil, the still point in the changing world is particularly the acute trusts, but there is a clear impact on us, which we're getting to understand all the more, the increasing financial pressures, the desire, the necessity that we meet our financial plans, but at the same time the opportunities as we look with our colleagues in ICB and the NHS England who are facing particular personal turmoil, there's also the opportunity for us within, as a trust and within the Alliance, to see how our future role might change. So that was my first main kind of reflection before we start this board, and the second one was I'm just glad to feel that we're still continuing as a trust to be progressing with our strategy. Those of you, and it's almost everybody who was at the Governor's last night, was able to listen to the Lifelong Care Strategy update, which to me is just really exciting and shows that we're thinking beyond, out of the box, beyond our current way of thinking, and embracing our need to change in the years ahead. So I want to just record my thanks to all those who've been involved in developing and rolling out the Lifelong Care Strategy. And happy to take any questions relating to that, but otherwise I'll take us on to Bijou and the performance update.
Yeah, so you'll see the dashboard in your packs. So just a couple of highlights from here. Our financial position remains strong and on plan. I went through that in quite some detail yesterday at Governors as well, but we're on track to deliver our planned surplus of 13 million for 24-25, and alongside that we've got a really ambitious capital estate programme, probably fair to say probably one of the biggest ones nationally, and that continues to move and develop with a plan to invest, I think by the end of this year, 93 million, which is terrific, I think, both for our patients and our staff. From a performance point of view, there's a couple of areas that have dropped this month compared to others, so particularly the 62-day cancer position. You'll remember from previous months we've been quite successful in moving to compliance there against the constitutional standard of 85%. We always knew January and February were going to be difficult, and the team were working on moving us to a March position that will hopefully be closer to the 85%. And then just in terms of a couple of points to highlight around from a strategy point of view, we'll see later on the agenda, we've got our annual plan for our plan for the year ahead. Business units have been, and corporate services have been busy identifying the areas that we're going to have a strong focus on for the year ahead. Part of that is the lifelong care strategy, but there's also more in terms of general improvement that we want to run throughout the organisation around length of stay. We have as well, as you'll all be aware, I've got good working relationships now across the Alliance. And work in terms of delivering improvements for patient care continues particularly strong between ourselves and Newcastle through our bilateral board arrangements. For those that may have missed it in the Health Service Journal, we're now out for recruitment in terms of a shared chair across ourselves, Newcastle and Gateshead as well. So overall, a really strong position despite some of the pressures. So sometimes I think we can kick ourselves because we haven't quite met some of those constitutional standards. You'll see our sickness rate isn't quite where we want it to be. But when we benchmark ourselves with others, not only in the patch, but also nationally, we remain a very strong provider.
Thank you, Bijou. As we know, all elements of that dashboard have already been scrutinised by the relevant committees, and so there's been plenty of opportunity to dig into the detail. But here's the opportunity at board for anybody to raise any questions or comments or challenges to Bijou. Then I think we're ready to move on to the substantive items on the agenda, and we're into the performance section. And first of all, we've got the opportunity to consider how the Community Services business unit is proceeding, look at its successes over the last period, and look at some of its plans for the future. We've got Laura Mackay and Terry Clayton here to present. Is it, Laura, are you front of stage first of all?
Yes, she is.
Yes.
There you go, that's good. Over to you, Laura.
Thank you for this opportunity to come along. So I am Laura Mackay. I took over from Paul Pays on the 1st of December, and I've been very well supported, so thank you very much for this opportunity to come and update you. So, as I think you know, the Community Services Business Unit is a very wide and diverse team. We have quite a large reach throughout the community, and we are endeavouring to further that reach all of the time with the diverse services that we have. Our achievements over the last 12 months, we have, this could be later down the agenda, but you know, financial balance and SIP achievement has been made, and I think in the current climate that's really important. We held a very successful virtual wards national event at St James's Park, where we shared best practice, but also tried to understand and evaluate our virtual ward. And I should say as well at this point that we are moving towards a slightly more patient-friendly term with hospital at home, but for purposes of national reporting, virtual wards is that was what the national event was. We have completed and embedded an out-of-hours district nursing review with great outcomes, both from a financial perspective but also from a working hours perspective and patient care perspective. We've had extension of the North Tyneside sexual health contract, which again is very important for our patients and our service users. We've also had a substantial recruitment into the wheelchair services department, which again we have a sort of transformative programme to really get that back on track. We've had some successful recruitment into the occupational therapy team, and we sorted out our intermediate care beds, which have worked well for us over this winter with significant pressures, and we've had very good collaborative working with our colleagues, for example NPC and our out of hospital board. A look back to 2024, just again, I mentioned the district nursing, but we've also been using a new Ardens template to improve long-term condition management in district nursing, and also using the Cardia mobile ECG devices to diagnose atrial fibrillation in the community. Again, wheelchair services, we've had a real focused recruitment drive, and we have a new plan to get that service on track. And we've had some great work by the paediatric occupational therapy team with sensory processing, and that was a co-produced with the Northumberland Parent Carers Forum. Adult speech and language therapy, they've really led the way in terms of embedding shared decision making into their clinical practice. The palliative care team won an award at our session showing that informal care administration of PRN subcutaneous medications at home for end-of-life symptom management is possible and can be really powerful. North Tyneside Talking Therapies have developed some group-based interventions to support population whole experience psychological symptoms during menopause, and the Learning Disability team have also been working collaboratively with public health to drive down health inequalities for people with a learning disability. And again, the NS nursing team have been doing some routine systematic reviewing regarding perimenopausal symptoms and menopause in this patient group. Going forward, aligned to our business plan, we're trying to support our patients and people, aligning our services of both planned and unplanned care, and trying to review our community services in response to the financial pressures in SIP. We hope to and plan to expand the single point of access, and we're currently reviewing our palliative care model to extend the working day and hours to again be more responsive to our patient needs. And we are supporting the decommissioning of the Care Northumbria service. We continuously try to innovate and improve our services. We're evaluating presently the virtual ward, which will be hospital at home, with an aim to again continue this provision and important service. And we also have a new enhanced discharge team, which again we're going to evaluate and hope to embed. And we're also developing a care home strategy in the hope that we can actually try to keep some of our patients at home with non-inferior care and I suppose stop them ever coming to our front door and waiting on trolleys for hours. Going forward, we want to support economic growth, tackle inequalities and climate change, and we'd like to expand the Making Every Contact Count training and poverty proofing, and a lot of the work is being done by our public health, trying to weave into the other business units and services within the Trust. We're trying to develop our community estates, specifically the sexual health estate in North Tyneside, which is currently on award there and obviously is not ideal. We're growing our people and keeping them in terms of our allied health professional apprenticeship model, and also making progress digitally in these areas with System 1 expansion and the new wheelchair services and sexual health IT system. So going forward, the challenges, obviously SIP is relevant for us all and very important, and we have to look at our productivity and our efficiency. We're trying to use data to, I suppose, understand and direct how we do this. The left shift is really, it is our, I suppose, mandate, and we have to do this, and now is the time for our patients, and I believe that the community services business unit is how we're going to do this. And obviously we've also started to plan for winter 2025 now that we've just finished 2024. So thank you for that opportunity. I'm happy to take questions.
Well, thank you. Really clear. It feels like your ambitions are pretty extensive, and I know there'll be quite a few questions. So let's start with Steve. Can I remind people we need to use the mics because of the online process? Steve first, and then I've got Margaret.
Thank you, Laura. Great presentation. Good to hear an update from you. So the stuff about developing a care home strategy, I was just wondering what sort of governance is around that and what the next steps are.
So we're just really at the beginnings of that, and I suppose we've got some new working partners in one of our locality areas, and I think some of that's about identifying that a large number of patients can be conveyed to our emergency departments where they'll wait for simple blood tests, and often they have ceilings of care such that they may not be for lots of treatments, but actually if we could deliver fluids, antibiotics and treatments in their care home, that may prevent them never needing to be conveyed. Or alternatively, once they've had an evaluation, be that remotely getting them back to the care home sooner, which again is often a much more, I suppose, patient-centred and family-centred approach, because the family and the carers and the care home know them. So that's our plan. We're not, in terms of governance, we're just at the beginnings of trying to work out pathways, but I think there's a real appetite for this, both from a community perspective with the primary care and the care homes themselves, and our care of the elderly positions and our emergency positions. And we have our district nurses and our virtual ward team. We've been doing a lot of step down in terms of frailty, but now I think we need to focus on the step up model.
Yeah. Margaret.
Thanks, Laura. Laura, Tracy, great presentation. I just wanted us to go back to the expanded the poverty proofing concept. Just have a little bit more detail, and then how are we communicating this great work to our colleagues across the Trust?
So Jill Harland is our public health consultant. We've just appointed, or she's not started yet, but we've appointed a second consultant. Jill's leading the Health Inequalities Programme Board, but we're trying to weave that into all of our aspects of, and I suppose looking at the impact about, service users who, are not as able to, and I think that's in every part of the work that we're doing. We're trying to evaluate the impact, and it's a real challenge. But I think the public health team they have grown in number, and we're certainly committed to continuing their work. And I'm confident that we have the impact they're trying to weave into all of the different boards rather than just working in their own silo. Terry wants to say something.
We've looked at this in some detail at the Health Inequalities Board with them and giving it a strong encouragement. Jeremy?
Can I just add to that? So the speech and language therapy team, the paediatric one, really embedded poverty proofing. So we've got like a template that they use that we're using with our other community services house, and they successfully did it as well.
Very good. Jeremy?
Yes, so that was what I was going to say. It is mainly an investigation, but at this point an evaluation to children, working with some teams. And as I say, I was at the quality panel and that was presented, and they did that very well.
Great. Joe?
It's just at an organisational level in the staff say they were actually asking staff about their awareness of the poverty proofing training and then link to where that training is as well.
Oh, that's great, Jill. I was actually with the public health team on Friday afternoon, so and I'm going to go back because they're doing a lot of great work, and just not going to have it. Unfortunately, I make the steering very well, so yeah, that's great. Thank you.
Excellent. Richard?
I'll echo everybody's views. Great presentation, and well done on achieving cost improvements. Not the nicest part of the job. Just a couple of questions, not completely related on people. First of all, we know it's been a pretty brutal winter. Just some reflections on how it's been for your team and how they've coped with it. And secondly, People and Culture Committee yesterday, we were looking at the stats for abuse against staff, and obviously some concern with community people because they are by themselves, rather than perhaps in the hospital environment where there's a support network immediate around them. Just your reflections on how staff feel and any help you can give.
Second.
Okay.
I'll take your second question first. So, particularly in district nursing, because they're often walking into a house that they don't know what's behind the doors, we've got a really robust system. So if staff highlight any concerns about the household, we do what we call a risk to staff meeting immediately after that. Datix will go in, all the staff come together with safeguarding, if we have to put protect forms in, and we may put in additional safety around that, so visiting in pairs, or putting a letter out to the family and saying, remove the dog, or remove the weapons, or whatever it might be, or stop smoking, or whatever. So we've got a really quite robust process for that, to manage that.
And how was winter?
Winter was tough, really hard. So I think our community, colleagues, our services, they have almost wrapped around a lot of our teams. They have, I suppose, really tried to prioritise taking patients out of hospital, being really responsive. The kind of the boundaries between hospital and community have really kind of, over the last 18 to 24 months, have come down, and I think this winter was even more evident. Our community matron was walking the wards, identifying patients to take home, and really everybody, there was a real kind of movement of trying to make a difference, and it wasn't just medicine's problem or surgery's problem. So again, I think that's a way of working that is now well established. I think our community teams, I think they ever want to do more and more and more, and I think they've struggled perhaps to maintain their normal sort of district nursing services when they've been pushed and pulled, but we have said thank you, and they know that they're valued.
Thank you for that. Simon?
I was just going to kind of reinforce everything. Laura's first slide shows it's a very big business unit with lots and lots of business, and the acute side of it, if you like, is only one part of it, but it's been so helpful to the system, to medicine emergency care, certainly. For the last couple of years with virtual wards hospital at home, every time we've asked something, we've ended up asking way more than we ever asked in the first place, and the teams have really, really responded to that. So I think they've got a big challenge. We've all got a big challenge this year, because actually our expectations to get even better for next year. And the point that Laura was making around when the hospital's really not adding any value, or quite often adding negative value to people's lives, then we absolutely need to find alternatives. But the community business unit are the source of some of those alternatives, or the supporter of that, and so we absolutely need to help them deliver that. So thank you, guys.
I was quite struck by the high proportion of the interventions that you're responsible for seem to me to be running alongside primary care and working with primary care. And I just wanted to ask Katie, the perception of how effectively NPC is interacting with community services, and if there's anything we at board level should be reflecting on about that.
Yeah, no, thank you. It's been a good job. Terry attends all the board meetings, board development meetings for NPC now, and David vice versa. So the engagement with community service is great. The clinical strategy has community service within it and is thought through and got their input into delivering that particular prevention and care in the community. So it's working really well, and I'm pleased how it's developed over the last 12 months.
Okay, that's good to hear.
Yeah, I think it's fair to say as well, obviously community services have a good link in with NPC, but they work across all of the practices that we cover across North Tyneside and Northumberland, and whilst they're not sitting at a board meeting because of how we're constituted, I think the input that they have into each of the PCN stroke localities is great now, but it's only going to have to get bigger and more enhanced as we start to move people more readily out of hospital and into neighbourhoods in the future.
Great. Any more for any more? Steve?
Maybe a wider question, but obviously you mentioned in the presentation the decommissioning of Care Northumbria. I was just wondering, really, maybe a board question in its entirety, how do we learn the lessons from the reasons why they didn't work, but not lose sight of the objective and what we were trying to achieve, and make some momentum going forward for trying to resolve the same issues in perhaps a different way?
Let's take that as a question, but let's remind ourselves that we've also got it on the agenda for this afternoon with a paper. But let's have an immediate response to that. Do you want to take that, Marion, or is that for Laura? Or Derek?
So it came into the business unit to operationalise in 2023, and we did that really successfully, and we had really good staff when we did the recruitment of it. I think the model, whilst when it was set up at a point in time. So we've changed, the landscape has changed. At that point in time, our DTOC list was quite high, wasn't it? And getting people out to have care provided at home was really difficult. That's changed now. So I think what we've done is just reflect the change in landscape and the change in care provision that is both in North Tyneside and also in Northumberland. And I think that's testimony to our local authority colleagues, because they've really stepped up and working with independent care providers. So reflections from our point of view, from the community, is it operationalised really well. The staff came on board. They felt very, very supported by the trust, which I think is, again, testament to the trust and its values, and they really bought into that. a lot of the staff that we employed were new to the NHS. I think, again, one of the positives is that we're going to be able to keep those staff. We've trained them really well, they've all gone through the care certificate. When we told them that we were decommissioning the service, their first comments were not about what about me and my job. Their first comments were, what about the patients, what about the clients, who's going to look after them if we are not? And I think that's because of how they were embraced into the trust.
And we had the right answer, which said we will carry on looking after them until an alternative provider is available, which is good. Yeah. Okay, can we take that further later on in the this afternoon's agenda? We can go that. That's very good. Any final questions or comments to Laura and Terry? This has felt a bit like a Love-In, really. I mean, it feels like the board is very... Yeah, go on.
Well, I'll leave within the challenge, and I think it was Simon's point as well, and it's all about challenge. It's not just Laura and Terry's, clearly. And we will have a further discussion through boards, because the board will have to sign off our winter plan, but just how we do winter differently this year. Both from a staging point of view, depending on the severity of what hits us, but also just making sure that we've got the right people in the right place, both from a patient point of view, but also from a staffing point of view, and that all in the context of some of the financial challenges that the system has, I think will be the trick balance that we're going to have to try and achieve.
That's it, right. So my attempt at a summary, the services are clearly much appreciated and valued at board level, and that's come over with what I naively called a Love-In at the beginning. We like the service you're offering, and we like the way in which you're presenting it. Terminology, thank you for looking to incorporate hospital at home. We do not have to be dominated by government's terminology, which is why next presentation, see if you can avoid left shift, please, which sets off antibodies in myself in particular. We had good assurance around the care home strategy and the way in which that's developing. I think that's going to be really important as we move it into winter. I think we've had real encouragement about the rollout of the poverty proofing initiative, which I do believe is fairly fundamentally part of that shift towards prevention as well. And the more we can start recognising that tackling the social determinants of health has to be part of our role as well as other people's. We recognise that the board's winter plan is going to have quite a substantial chapter that's dependent upon community services. We're going to need to see further expansion, further development and further initiation. The issue of staff safety is something that this board has put a lot of focus on in the past. So although we got, I think, a pretty strong assurance from Terry that we've got good processes in place, I think we need to continue to ask that question. I think that community services and Terry and Laura should know that if there are other actions we need to be taking to seek to support the safety of our staff in the community, the board will be open to suggestions and requests for doing something more. We had encouragement and assurance also about the quality of the relationship between community services and NPC, and that's really encouraging, because I think that way the future lies. And there's more to go in that, and let's see where that goes. And we had encouraging reports about our Northumbria Care, and we will talk further about the future, not so much of Northumbria Care, but of our roles in social care, initially this afternoon, but also later. With that, does that cover the key points that were raised? And thank you so much, Laura and Terry, that was terrific. And let's move straight on this stimulating motion that's gone to oversight and scrutiny in North Tyneside. Have I got that right? With a fair bit of criticism of, in the past, local NHS bosses. I wonder who they were and the shocking decisions they took. At the same time, it's talking about the wonder of the standards of blue light emergency care around there. But it's tricky because how are we responding to this?
So we're waiting now from the Chief Exec of North Tyneside Council to formally write to us in terms of the outcome from that meeting, from that scrutiny meeting, and steps that they wish us to look at in particular. My understanding is from the meeting as well, there was quite a bit of discussion about the transport element of this motion rather than the ED, the emergency department part in itself. So I think our next bit now is just to wait and understand what they would like us to look at in greater detail, because there was a moment of clarity around whether they meant 24-hour open access urgent treatment or whether they actually meant 24-hour emergency care. And if you remember those that were around the table, I think it was a couple of years ago, there was a similar motion, but it was 24 hours around emergency care, and a working group was put in place to kind of explore that, and an outcome came from that, which at the time everybody was comfortable with. So there's just a little bit of clarity about whether that's what they mean or whether they mean 24 hours urgent treatment centre. We did cover that off at the time of that first motion about the numbers of attendances to the urgent treatment centre, particularly tailing off after about 9 o'clock at night. So we'll wait till I've got a catch up with Jackie, so we'll find out there.
But just to be precise, if the request was for us to be running an urgent treatment centre 24 hours at Red Lane, what would our answer be?
On the fact that there is a demand, that's not something that we would do. There is no demand.
There is no demand for that, so.
Obviously, if there was a demand, that would be a different.
Jeremy?
Yeah, so I mean, I just think some of the wording isn't clear, and
But forget the wording and go to the heart of what they're
there is something in it that I think is inaccurate, and that's saying they have no option but to go to any search for minor ailments. And that clearly isn't the case. There's an absolutely excellent urgent treatment centre at Red Lane. It's done very effectively. It's just, I understand it's been well liked by the public and received.
And then what about the answer to their request for there to be a walk-in service at Battle Hill, which is only a short bus ride from Red Lane?
Battle Hill was a Newcastle facility quite some time ago that got decommissioned. At the time, I think it was the CCG, the Clinical Commissioning Group, that decommissioned that service. It's not one of ours, and I think at the council meeting that was clarified that it wasn't a Northumbria facility, so that would have to be taken up with Newcastle and the ICB.
Okay, that feels a bit evasive if I'm frank. I mean, do we have a view as to whether there is a need for a walk-in service at Battle Hill?
Would you effectively use as the current facilities?
Say that again?
It wasn't as effectively used as the current services that we're running at Red Lane.
Okay.
Didn't offer they didn't have radiology all at the time.
Okay. So, any other questions or comments on this? This is stimulated by Oversight and Scrutiny Committee in North Tyneside. There's no immediate action of this required, but we need to be able to respond to what comes out of it, and hopefully not just in the defensive, well, it didn't work that quite right way, but to get to the essence of it. And I think our basic answer is, our basic answer is that the demand currently is not that, but we're always responsive to meeting demand where it's legitimate and feasible. Okay, thank you. And Bijou has just reminded me of something I intended to say right at the beginning. Surprisingly enough, we are already in PERDA in the period running up to the council elections in May the 1st, which means we are already now required not to make announcements that might be seen as having any kind of political tones. We can discuss whatever we like, but we cannot make an announcement about a new service. I'm just looking at what's scared people to keep me straight. No, it's not sitting here. Whether I've captured that kind of right, we can have proper discussions. We don't need to impede our discussions today. But we can't come to conclusions, or if we do, we can't publicise them until after May 1st. Have I captured that right, Peter? Thank you for reminding me that I intended to come. Anything more on the motion? Then we're still in the performance section, and we've got the health and safety, fire safety and security report. Kate.
Thank you. Thank you very much. So I'll just run through a few of the highlights of the report. So since the last report, which the data contained November and December last year, we've had 98 incidents that have been recorded by staff on DATIX, which follows a similar pattern. And we've got the SPC charts within the pack that just show what that looks like over the 12 months. The incidents involving the abuse of staff, so I think there was a question asked around that within the community. So we had a really good session at our sub-board committee, People and Culture, looking at that, and that is progressing. The work is really progressing on that. So from a numbers perspective, there's been 124 reported cases of staff abuse. That is a slight reduction, but what we're focusing on is what we do about this and how we help and support the staff and what we put in place. There's some figures there around warning letters that we've sent, and we've had a good board discussion about this previously about whether they work or not. A decision was made to continue with those letters because they provide that comfort to staff that we are doing something about the issues. And we are putting a draft violence prevention standard together. So Kirsty Shotton is leading on that work and working with Stephen Thompson, and we're going to put that together, and I will bring that back in the May board report to share with board. The other elements I wanted to talk about, there was no issues with the internal audits, and actually we got good assurance on their management of asbestos, which is great. And then what I've included in this report for the first time is the NSEC remediation works. Now I know board get updated on it regularly separately, but I just felt it's important it's also included in this report. So phase 1 of the remediation works commenced on site, and the health and safety team are fully engaged with that project, and the fire team are also key to the project that's underway in phase 2. I also wanted to mention an issue that was brought up at the last board around the water fire extinguisher issue, which I think it was Damon that reported on it. That's now been sorted and work has completed on that within the time frame. There are some dashboards within the pack around, we were asked as an action last time to include some detail on the warning letters by site and departments, so hopefully that provides the board with a little bit more information. There is more work to do on that, and that work will be in conjunction with Kirsty, and we'll bring that back to board together at a point in time when that work's completed. And that was all I wanted to say. Thank you.
Okay, thank you. That's really clear. Let's start with Ruth and then Phil.
Sorry. Just one thing, Kate, which was about the fact that there were letters, the HVS at the North Tyne site, which made me slightly worried. But I appreciate we all sign up to things, but we've got our volunteers being challenged. That makes me slightly concerned.
Yeah, absolutely. So
assume it's by the front door, and that's why.
Yeah, it was, and I think whenever we've talked to Kirsty about some of these issues, that it's really helpful for us to meet with the staff and just get that perspective from them. So, it's not acceptable.
Well, none of it's acceptable, but it makes me particularly worried if we're picking on volunteers.
Yeah, absolutely.
Forces at the door.
Thank you. Do you want to respond to that, Marion? In which case I'll take Phil first and then Marion.
Just an additional point on the warning letters and exclusion letters. I think we've talked about this before, Kate, but do we automatically share those with at least our neighbouring trusts or not yet?
It goes on our system as an alert, but we don't share them with neighbouring trusts, no.
Is that because, well, that was my question really, which was, particularly with exclusion letters, because by definition, those are people that might be more likely to turn up at other neighbouring organisations, and I just wondered if there was a reason we couldn't share, and indeed vice versa.
Yeah.
Jerry?
Well, so I think that probably is an issue that is worth exploring, perhaps at alliance level. So there was a customer at North Tyne, at Newcastle, who was excluded, but they were excluded from a service that only Newcastle provides, so it was quite tricky. So I think it probably is important because there will be a population who use both sites.
It feels a bit equivalent to safeguarding alerts, really, where it doesn't mean that somebody else would not see them. It would mean that they would be alerted that there may be some particular cases. It's almost like a reasonable adjustment.
I have asked for more detail around, so when we do issue a warning letter, how many times does that individual come back? Because obviously we would treat for life or limb, but not for anything else. So I have asked for some detail on the return of those individuals and whether the letters actually work.
Marion.
Thank you. I think it's interesting the rise from 23 to 24 about the warning letters. So I think that we should look at that positively because I think that it's about the importance that we're taking this and the seriousness of it all. But also I think people feel that we are doing something about it now and they are inclined to report more. So I think that is really good. And just we know that we are looking at the repetition of people coming back, and I know you're on that, we also look at that very closely in ED.
And I think the national sexual misconduct policy as well ties in with some of this work, so it's helpful that we can see all that coming together, definitely.
Joan.
Yeah, and just to say that we're going to cross-reference it with the staff survey results, so the questions that we ask staff, we're going to look by site and then cross-reference that with the work, the dashboards to see if there's any areas where staff aren't reporting but are actually talking about it in staff survey.
Has this been discussed at People and Culture? Oh yeah, Katie, sorry.
Yeah, that's what I was going to say actually. It was a good discussion yesterday, and backing up what Katie's saying, the data and the dashboards that Kirsty's putting together are really strong, and so it would be good to start to see the impact of that. One thing we did discuss yesterday at the People and Culture Committee was about understanding what isn't a norm. So abuse, verbal abuse can just be part of the role, but it shouldn't be accepted. So it's ensuring again that education for staff on what to report and where to report was key as well.
Good, thank you. Any more to Kate? We've had some assurances around the staff abuse figures. We're a bit concerned about the impact on volunteers in particular. We are understanding more, I think, than we did before this discussion about the positive nature of an increase in the rate of exclusions, but we are asking for consideration of whether an alliance strategy for sharing that information in a constructive way. I think those are the key conclusions from the discussion, in which case thank you very much indeed, Kate. Good stuff. And let's move on. Andrew, you're here, the Great North Healthcare Alliance update, and there's quite a bit of focus on the areas where we've got evidence now of actual positive change.
Yes, thank you very much. So I appreciate it's a relatively lengthy paper, but I don't think we've had the last substantive public board update for a few months, so we wanted to provide that back. This paper's been taken to each of the 4 trust boards in parallel. They're on slightly different days, but they're all coming this month. So it's an overview really, Paul, as you say, about work that we've actually done and started to see some benefit from. There's also, I guess, confirmation and just putting out to all boards and also putting out in public the vision, the foundations, principles for how we want to work and various things that this board has obviously seen previously, and then also what we want to work on and what those ambitions are. I think that the summary assessment kind of really says it all. I think we have started to see some positive progress. I think we reflect, and we maybe didn't do this in last July, the last public board update, but the kind of pace of the strength of building the relationships, I think, has really been one of the key things. Going from a point, and I think this is Jim's language that he used, but going from a point where the Newcastle board hadn't talked about alliance working or working more collaboratively to this point over the space of less than 12 months, as it was pretty good. I think we've seen good support as well from some of our external stakeholders, the ICB. We've had very supportive conversations with the chair and chief executive there. And I think we have also, as we've gone through the course of the last few months, been refining our approach in terms of the kind of day-to-day, week-by-week working, learning lessons about how we go about maximising the benefits from alliance working, how we work best with partners, where it's helpful to have some formal structures and governance that supports that, and where the more informal working groups and bilateral arrangements have really supported that. I think it's because we've been kind of reflecting on that we've actually started to see some of the benefits that we've listed in the paper, and I would expect that the kind of scope, the range of them would increase over the over the next period.
Thank you, Andrew. Opportunities for questions or comments? I guess we've all seen elements of this in various committees.
Well, we heard last night at Governor's, didn't we, from audiology, and that was for me, that was a massive shift, because that was something we were getting lots of noise about. We got a lot of unhappy customers, and we hadn't been getting much traction with Newcastle, and it did feel like there was a real shift there, and we see some real benefits to patients.
Yeah.
And that's where I think previously perhaps we've not had that traction, we've been able to get them to the table in the same way, so it's really good.
And there's an openness in that presentation to governors, but that openness is, you know, tenfold, I would say, in the kind of working conversations that we've been having. So that, you know, and I feel like Northumbria colleagues do the same when we're leading into those conversations. So it does, you know, we play off each other quite well.
As in not only evidence of the service improving, but the fact that the relevant director from Newcastle was willing to come to our governing body seemed to me to be quite a powerful symbol as well. We're simply ready to receive this report, but I think hopefully note with some pleasure that the evidence is emerging now of concrete gains for patients from the approach that we've been taking. I do think it's this is pretty well on track, I would say. I mean, I think in the first few months, people at all levels, probably all of us, were thinking, come on, let's just see evidence for improvement. But any of us who are involved in complicated partnerships know if you don't build the relationships first, you don't get anywhere. You might get fleeting improvements, but they'll go as soon as the tide comes in. These, hopefully, are ones that will be of longer lasting. And some will come and go. So, you know, we've got urology noted here for a bit. We had real improvement in outcomes. That's dipped a bit at the moment, but the relationships underpinning it seem to be at least potentially there to enable us to get a longer term, medium term trajectory that will be really positive. Anything final? Ready to thank you, Andrew, for your presentation. Look forward to seeing it again with even longer list of positive outcomes.
Actually, for a longer paper.
Not necessarily on the paper, just more positive outcomes, that's all. Great. Chris, we're into the forward plan. Now, this is something that we've really gone through in considerable detail elsewhere, really kind of scrutinised in early drafts and approved it at the beginning of the week. So there shouldn't be too many surprises in your presentation now.
Indeed, thank you. So, as you say, this is a presentation about the operational forward plan for next year, and this is, as you say, Chair, this really just collate the plans that we hear about across all the sub-business units and in board development in other forums. So things like we've heard this morning around winter planning, around operational planning guidance, around alliance work, the lifelong care strategy. Just it's a collation of all those plans and strategies into one document. So to say, there really shouldn't be anything there that we're not kind of familiar with already. So in terms of kind of just a couple of things I just want to kind of highlight and go through. Some of that external context is around, as we've heard before, around the 3 shifts. The treatment prevention, digital dialogue, hospitals, community, and kind of our response to that. In an internal context, it's been alluded to before, there's a lot of work and thinking and strategies around length of stay, length of wait, valuing patients' time more highly. And then we'll just try to summarise it kind of on this slide here. So if we just quickly talk about that slide, if that would be permitted. So in terms of how it all hangs together and fits together, if you're working from the left-hand side of the slide to the right-hand side, our main aim is our vision and delivering on our vision. And we see we can do that by trying to follow and collate our 3 key principles, our key 3 sort of vehicles for delivery of that vision, being patients, staff and improvement. So putting patients first, it's valuing staff and having enabled staff with the right tools and equipment, and then having a kind of improvement methodology running through that to make sure that actually we can get the most out of our staff and let the staff do the most for our patients. And in doing so, we'll focus on those key priorities for delivery, and they're being They've been brought up through a business unit planning process, another corporate function planning process, and there's the key ones there on the slide there. And if we're able to implement those key priorities, that'll mean the delivery of big signals. And as you recall, the big signals are part of our 5-year plan, and this next year being year 3 of that 5-year plan. So as I say, the key priorities do then link back to those 3 shifts. We'll talk about targeting supportive intervention for areas of known inequalities. We're looking at using digital systems differently. We're looking at how we use health call differently, RPA, for example, in the digital world. And then we've just heard from Andrew there around alliance work. We heard before about virtual wards or hospital at home. We talk about neighbourhood health plans. Alongside that is the operational planning, asks and requirements, and they're built into business unit plans for the delivery of what needs to be around in that respect. And as I said before, that kind of theme about that length of stay, length of wait on patients' time is that thread running through the plans as well. And then underpinning all that in terms of those enablers, as you see in the green at the bottom of the slide there, we have the digital, we have finance, and HR, etc. And we'll need those more corporate functions into the operational teams in order to deliver on the key priorities. So happy to take any questions or comments.
Thank you, Chris. That was very clear. And it's nice to see it all kind of in one place as well, kind of pull together all the different elements that different committees have been chewing over. See it in one place like this. Any questions or comments on it? Are we ready to receive it without challenging you? How about that? Yes? All right, particularly like that. That's great. Then we move on to the items for approval, of which we've got a few. And we start off with the final safety, quality and improvement priorities, which once again have gone through several iterations and have been considered at several committees, including at the governance. But here we are at board with a request for us to approve. Jeremy, you going to get us off?
Oh yeah, okay, yeah. So I'll be as brief as I can, but I'm conscious that the public probably haven't had an opportunity to formally see these yet. But as you say, these have been through a number of committees and haven't changed in the last couple of iterations. So are presented for approval. There are 8, and the first 4 are continuations of priorities from last year. So I'll race over those, but we're continuing for another year in terms of ulcer damage, and particularly focused on the orthopedic geriatric patient pathway, people who come in without ulcers, but who suffer fragility fractures and have a long length of stay in association with frailty. Reducing the incidence of postpartum hemorrhage, we now understand more clearly what the issue is, which is that we measure it quite carefully, and that we are now doing more caesarean sections, which are associated with a significant blood loss. So we're now focusing on reduction of that. Deteriorating patients, continuing with the recognition, realistic and respond themes of that, working with our teams to improve the identification of patients who deteriorate. And then in terms of patient and staff experience, I'm particularly find this important because we're at the focus of, and we'll hear about it in due course for the patient charter. So these are the new, or the new and updated priorities on some familiar themes. Item 5 is to improve the cancer faster diagnosis standard. We had a safety and quality improvement priority on prostate cancer last year, and I think we've learned from that, and we're using some of the experience gained in that across all of the cancer tumour sites to improve the faster diagnosis, which is about informing patients by 4 weeks into their pathway. 6 is very new, so it is to have a proper look at improvement for our complaints process in line with the most recently updated and published standards, something that probably is due and it's very well.
And that was very much triggered by the discussion of the last public board.
Number 7 is coming out of health inequalities, and is to look at attendance at outpatient endoscopic procedures, particularly with the health inequalities lens, using some of the tools that the public health team have identified and applying those to that particular. And that's a really pretty big project we run endoscopy services. I'm going to say 5 sites, I'm looking at Marion.
Safety and medicine.
And then finally, item 8, which is to improve the safety of medicines at discharge process. This came out of a large PSII that we held last year, and it's to start on a few key wards to establish the process. We're doing it at a time where we will have just changed the discharge documentation pathway through an IT strategy with David's team. So that's to deal with that. I suspect that if we're able to implement and sort of lay a glove on that process, that will take 2 years to run through the organisation if we choose to do that. So these are just an overview of the next steps, which is to approve this list. We have already started, as part of the quality account process, going out to partner organisations and discussing them. And these are just some of the areas that have been discussed.
Jeremy, thank you very much indeed. Just to remind ourselves how this set of 8 priorities has emerged. First of all, there are a lot of other things that are priorities for the organisation, or the constitutional standards and the performance standards set by NHSE. We kind of take them as read, don't we? But then these are the kind of things specific to us. Chris, do you want to comment on that? And then I'm going to ask maybe Joe to reflect on how we've engaged patients and governors and people in white people in this construction.
I think absolutely right. We could have a list of 20, 30 plus. So in some ways this is just a small cohort of the areas that we could have, and that's not to say that all those other areas we're not doing work on, because there will be work going on in all those other areas just won't be identified in this as a safety quality priority. So in terms of how we've come to this list, it's a kind of a triangulation of things that come with SQ&I, data exists, things we know around the complaints when we know that we've seen the data on that and actually want to improve on that. So it's a real triangulation from a variety of sources that kind of boils down to this list.
Very good. Joe, how have patients been involved? Patients, governors?
So I know Ross and Laura will oversee the formal process of the governor and public governor involvement, but also our lay representatives have been involved in those discussions around our priorities in particular.
Thank you for that. That partly reminds me it would be a bit awkward if we now decided to throw this lot out and start again, since it's gone through so many processes. But let's take any challenges or questions or suggestions. With a bit of luck, yes, Andrew.
It's just a suggestion really. I don't think we've been through it with this lens at IM&T committee, but given that one of the next steps is how IT and technology link into each of these, I wonder if we should just have an item just to say what we're going to do with each of them. So I'll pick that up.
That's a really good idea. And in particular, this is owned by Safety and Quality. I can't think whether it was Alan or Maria that would have been chairing the relevant meetings that discussed, but are there any highlights wanted to be brought from SQ&I discussion? No. No, okay, we're all happy with that, all endorsing it. I think we're about to approve this set of priorities for us for the coming year, with the request that IMT has a look to see what their contribution should be. Good, excellent. Then Paul's next up, and we've got the internal audit annual plan. This is a very exciting document as well.
It's the most exciting document on the agenda.
Yeah.
I'm sure you that. So this is the annual audit plan for 25-26. The plan has been to the audit committee Just for clarity, it is the group audit plan, so it encompasses all subsidiary companies, etc. So it's comprehensive in that nature, and it takes account of the trust BAF and other factors, where legal assurance, etc. NEDs and exec directors have had a role in formulating the plan, and as I said earlier, it was approved at the Just one point of correction. We've extended Marion's role even further to cover the medicine business unit. So the responsibility for that particular audit will need to be allocated somewhere else.
I think you're happy with that,
Just put Marion down for everything.
all of them, simply, she won't, not got enough to do. Yeah. Richard, Chair of Audit.
Yeah, so this is recommended by Audit Committee for approval. I think probably fair to reflect Audit 1 would say that they get one of the most robust discussions on audit plans when they come to Northumbria, and I think that is indicative of the level of engagement by both execs and non-execs for the planning process. Just one highlight I'm going to pick out is 26 days of audit time allocated next year for elective care waiting lists. This could be really helpful if we get it focused on the right things. So I've said that I think there needs to be almost as much thought on how we plan the audit as there is in reviewing what comes out afterwards. There's lots of things they could look at, some of which will add value, some of which might not add value, and we want to, I think, focus on the areas where we feel we need the most value adding as quickly as possible.
Do you know, yes,
I would really support that, Richard, because I think Chris and I have had numerous conversations, because you can chunk that pathway up in so many ways, and I think that both from a waiting list management point of view, but also kind of actually getting to an end point, would be really positive to have a look at, and actually how the PTL is managed in itself as well.
that's a really good point though about the preparation can be as useful as the audit itself. And I wondered if the same point might occur with the audit on access to transport, which feels to me to be potentially not just a kind of tweaking the systems, but maybe something fairly fundamental coming out.
Yeah, you could have 1,000 audit days on that particular subject. So yes, I think what we're trying to do now with the Audit Committee is to focus on those that we know where there is potential that the scope may not, but we want after the event to make sure that we pre-agree the scope in a bit more detail, so that we don't go in with this nice report and not what we wanted. And I think there are a few that risk comes along, and I think you could examine very good on there as well.
Okay, good. Other comments? I mean, it's a long list of audits. Are there any things that people think, why haven't we got it in? Virtual wards, I think, is on the, we haven't made it this year, we'll do it later, and the financial impact of that, and I kind of was a bit surprised.
Yeah. So the list was 60% oversubscribed, which is a very good indication of management appetite for internal audit activity. Inevitably, when you've got such a large cover to do, there will be things that you would have wanted on the list. There is contingency in the plan, and I think if that contingency doesn't get used up, then we can use it later in the year to focus on some of the items. Certainly some of us would like some audit attention on fleet as well, not because we're worried about it, but because it's a significant element of the Trust's operations. So I think that's something we can iterate during the year, but there is limited capacity of Audit 1 to develop, to deliver more, and I think it's a good balance.
You know, there will still be internal monitoring challenge in terms of virtual wards, so we'll no doubt we'll have some reference back through FIP at some point in the year around the financial position of fleet. The virtual ward and how it contributes towards saving inpatient bed usage, etc. So there'll still be some report back through.
Thank you. And has any consideration been given to auditing the Alliance, either for cost effectiveness or for any of its systems? And not the Alliance per se, but maybe aspects of the Alliance.
I think that may be something we need to have a discussion at the Alliance committee.
Can we just kind of log that to somewhere? I mean, it's not just our responsibility, of course, but that's one of the problems. You know, each of the trusts has got its own audit schedule, and who's looking at the cross connections.
So the audit committee chairs do meet fairly regularly, and it's certainly on our horizon at some stage, particularly when the joint committee starts doing substantive things that there will need to be jointly commissioned internal audit work. It's quite a few protocol issues need resolving at that stage, but yeah, it is on our radar.
Good, thank you. Any final comments? I don't think we should try to second guess the work of the audit committee and all the people who built up to it, so I think we should approve this. Noting that actually the preparation for appraisals can be, for audits can be as important as the process itself, and just asking for, at some point, consideration for virtual walls and maybe to encourage the audit chairs collectively to reflect on how best we can bring this methodology to bear on the Alliance as it takes an ever-increasing importance in our work. Happy to approve on that basis? Good. Melissa, this is you now, the Register of Interest, which is fascinating, but I'm not sure if it requires enormous levels of debate.
No. So it's just part of our annual return, so it's the Register of Interest for the board and MPC and NHFM to present it to the Audit Committee for approval, so it's just here for approval as well.
And Katie wins the award for having the most interesting. Katie is the most interesting board member. Any comments or happy to receive?
And where does she find the time?
Where does she find the time? We can all learn something from that, can't we? Yeah. Good, okay. Are we ready to move on to the section on patient and staff experience? And we start with the gender pay gap reports. Okay.
Thank you. I'm going to run just very quickly through each of the gender pay gap reports. So I'll start with the trust. So just as a reminder to board, this is a snapshot of information as of the 31st of March 2024, which we're required to report this year. So it's the second year that we've produced a gender pay gap dashboard, but the first year that we've provided additional infographics around ethnicity, disability and sexual orientation. So a couple of highlights. So the mean GPG is reduced slightly for 2023, and similarly so has the median. So that's positive in terms of the direction. Again, as in previous years, the gap it's significantly impacted by medical and dental staffing group. So when you exclude those from the figures, our gender pay gap is 1.5%, with a mean of minus 3.2. Sorry, mean and then 3.2 for the median. So it happens every year, but it's just interesting to take those staff members out and see what it means for the rest of the organisation. So the bonus pay for the trust, so this is predominantly the commercial team and its discretionary points for clinical excellence payments. Now, clinical excellence awards have stopped, but consultants are still eligible to receive previous points that they have been awarded. So the bonus gap's actually increased to 40%, so the average bonus pay for females is just over 5,000 and for males it's just under 9,000. In terms of regional benchmarking, we very positively are the second lowest within the region, and you'll see in the papers that we've got an action plan that we've drafted, which is included in the papers, and we've agreed People and Culture Committee that will review those within 6 months to make sure that we're on track for next year. So just in relation to ethnicity, disability and sexual orientation, you'll see in the papers that positive findings from an ethnicity perspective. For sexual orientation and disability, there's still work to do with the trust. But I think given it's our first year that we've produced the dashboards and it was a request from as an outcome of the board and from myself, I think we've got some really good data there to be looking at. So just regarding the subsidiaries, MPC are now required to do gender pay gaps. This is the first year that we've done for them, because they've got 505 employees and 500 is the threshold. So the mean gender pay gap is 45% with the median at 72%. So it's very high, and I think the gaps are attributed to the disproportionate rate of males employed in the higher quartile, so that's your GP salary individuals. Male employees, interestingly, only make up 14% of the workforce. Sorry, females. Males make up 61%, so that's where the shift is. There are actions that have gone to MPC board in terms of the reduction, and it is going to go back to a group that we've set up around the gender pay gap reporting, just to see if there's anything else we can put in place there. Really positive for NHFM, and I was at the board, the NHFM board, where this was presented. So they've seen a further reduction in their gender pay gap, which is fantastic. They've done a lot of work in NHFM around encouraging females to come into those, probably I'd say traditionally male-dominated roles, such as craftsmen or electricians, and that's part of the apprentice route as well, which is just really, really good to see. And actually, if you look at regionally, they've come up with the best from an estates and facilities perspective, so it's really, really positive. And again, we'll review the action plan within 6 months. So that's the overview of the three areas.
That's terrific. I feel like I should invite Veronica first to contribute, to tell us how you've managed to achieve such a almost non-existent gender pay gap within NHFM.
Thanks very much, Paul. No, it's really gratifying to see it. I think it is down to the work of everybody in the teams there, particularly on the estates side where Kate's indicated. I think there's still more to do though. I mean, I'd like to do more with apprenticeships. We've talked again, and when Kate was at board, we mentioned that again about just making sure that these things are happening in reality. We've got so many I think the structures are correct, and it's just making sure we continue to work with them. We've also had a bit of success within the capital teams. Johnny Watson is our Deputy Director of Capital, and he's done some successful recruitment, and that's often been an area as well where it's difficult to get women in, and there's been an improvement there, so that's very positive. So yeah, I think they're the key things, and I think also just looking towards progression for staff is a big thing, and flexible working, and I think they all contribute. So it's a variety of different things that we've brought in and continue to work on, and it is great and very gratifying to see, but there is still more to do.
Thank you.
I think just to add on to Veronica, the percentage of female staff that now are in the first quartile for NHFM has risen, and so we're recruiting into more females into more senior roles within NHFM, which again is really positive.
That's great. Yeah. Margaret and then Chris, I might invite Katie to comment on NPC. It's not quite such a glorious picture there. Margaret.
That's exactly what I was going to say. Great work from NHFM, but it is concerning looking at NPC, the disparity between the two. I particularly get it about some of the colleagues, the medical colleagues who are much higher salaries, but it's really good to see a full action plan because that constant.
Absolutely. And with it being the first year, Margaret, we've obviously got a position statement now, and we can do something about it, and we can put an action plan in place to work on it.
And if a lot of it is based on having a lot of male GPs in NPC, they kind of inherit practices that come in. So we need to have a bit of sympathy to Katie. But Katie, any reflections on that?
Yeah, a little bit of sympathy, because as you're saying, we do acquire what has been set up for years in other practices. Just as Kate saying, it's the first year that we've actually been able to see, so it's been really, really useful. We've got a workforce strategy in place now for the NPC, so there are clear actions coming out of that, and we've fed back to the board very regularly. So there is an awful lot of work going on to improve this and ensure that all roles are open to anyone who's got the right skills.
Yeah.
Very good. We're required to see these reports annually now.
Yeah, to approve, yeah. We need
okay.
to submit before the 31st of March.
Chris.
So if you just look at the graph there, I'm not sure that we looked at male or female split for medical and dental in NPC. There's a high percentage of females in those groups. I'm not sure that holds that it's a male GP issue.
Oh really?
Anyway, that was my point. My point was around Gender for Change actually. And
yes.
If you think about Gender for Change, and one of the reasons why it was introduced was around equivalence of role, wasn't it? Around making sure that there's value. And has that then seemed to have worked in NHFML in terms of that you've got two, or one traditionally female, one traditionally male, actually, as the Gender for Change made those equivalent?
No, so this isn't about equal pay, so we need to be really careful when we're talking about equal pay and the gender pay gap. So everyone receives equal pay in the same band. It's not really anything to do with Gender for Change. It's about attracting females, and it's about looking at why they aren't progressing potentially and earning as much as males. So I think what NHFM has done is open up their recruitment to say really targeted approach around females entering things like medical engineering, craftsmen, and so getting the females within those staff groups has been really helpful, and then you see that as people progress in their careers. Yeah.
Phil.
Just had a question on the dashboard and the report, gender pay gap. I was just interested, I looked at the overall percentage, female to male, is broadly 80-20.
Yeah.
When you look at the quartile analysis, it's quite similar. It's actually slightly higher for females for quarter 1, 2 and 3, and actually it then drops in quartile 4. What surprised me was that then translates into such a significant difference in the hourly rate for staff. Because on the face of it, it looks like it's pretty consistent, and if anything, there's more in the first 3 quartiles than the lower quartile. So there must be something around when you look at the spread in the quartile, there's more males at the top of that quartile. I wondered if it's something that's worth kind of looking at, because on the face of it, it looks strange that we end up with such a significant gap given the distribution.
Yeah, now when I look at that, it's for medical and dental colleagues, it's traditionally male colleagues that have higher earners in that category, but as you can see, the gap's closing and females are then going in, and it's that flexible working approach that I think Veronica mentioned, that we're offering that a lot more, so they're able to do those roles. But I will try and represent that, Phil, in the next dashboard. Yeah.
Anything more on the gender pay gap? There's clear evidence of progress, and for which we should be grateful. On the other hand, if we continue this rate of progress, it will take an awful lot of years before we get down to a zero gender pay gap. But we kind of recognise some of this is really quite complicated and is out with our particular powers. Nonetheless, we've probably got some extra learning from NHFM. We've got a bit more data analysis to do that Phil's picked up an apparent anomaly. We should be offering NPC any support that they need. But on that, having noted those points, are we ready to approve the gender pay gap report, including that set of next steps? Quite a comprehensive action plan has been set up. Yeah? Good, ready to approve? Excellent. Thank you. Now we're into the annual NHS staff survey results. Colleagues, once again, this is one where anybody that was at the Governor's last night has had some presentation of it at SQ&I and at People and Culture. We've gone through this in considerable detail, but there's hardly anything more important than the NHS staff survey. So I have asked Joe to keep it brief because the presentation itself is clear and most of us have gone through it, but to bring out the top highlights for any challenge or questions that we want to raise. Joe.
Thank you, Chair. Just as it is a really important survey, it's actually the biggest workforce survey in the world, the NHS staff survey. So it's an annual survey, and the results were published on the 13th of March. So in terms of the headlines, I think our engagement from staff in actually taking part in the survey yet again has been excellent. We've had our highest response rate as a trust, and our subsidiary NHFM and our bank staff also have their highest response rates. And NPC just being slightly under where they were last year, but they, again, still a very strong response rate. The staff survey is split into 9 themes and elements, which are called the People's Promise, and Northumbria had 2 best scores in their group, which is acute and acute community, and we just narrowly missed 2. Those where we are compassionate and inclusive, and we are recognised and rewarded. And the 2 where we had the best scores where we are safe and healthy, and morale, which I've said this before and I'll say it again, I think morale, particularly in our current climate, to have the best score is to be celebrated. And when we look at our scores overall and we benchmark ourselves against our group, which is 122 trusts, we were tied 8th. So again, an excellent performance. So this graph just shows you our performance over time, and you can see we've had our highest response rate since being a census survey, which is over the last 3 years. And this table shows you, so the yellow stars indicate where we have the best score in our own group, and the 2 on the end, which we've highlighted because we think it's important to highlight where we really just narrowly missed. The one I would point out to the board is we would work flexibly. We went flexibly, sorry, and that is the only one where we were under the average. So that is an area for focus for us, or continues to be an area for focus, because we have been doing work on that over the last year. So we move on to our subsidiaries. So this is our bank staff. I think everyone will agree it's excellent performance. So there's 2 sets of stars. One is where the bank staff score is higher than the best score for our group, and the blue is where bank staff have a higher score than the trust score. So lots of blues and lots of yellow stars on that chart. So excellent performance, and well done to Claire and the team for supporting our bank staff. NHFM, again, 3 blue stars where they've scored higher than the trust morale. We went flexibly, and we are safe and healthy, and then 2 best scores, which are, again, we are safe and healthy and morale. Unfortunately for NPC this year, they, after last year, their performance has dropped slightly, so there is no best scores either at trust level comparing to Northumbria or comparing at the best score in our group. Ooh, sorry. And these are, so this is, I think, my reflection on the survey is overall is that the trust, when we look at ourselves regionally and nationally, we continue to have really good, strong performance. If we benchmark against ourselves, that's where we start to see a real area for focus in terms of we're starting to see that change, small change, but we're seeing that change in a decline in very small proportionally across the board, and particularly in certain area questions, and I think this slide demonstrates it well. So here we see that it shows the difference. So where we significantly improved, we had 3 questions, that's versus 38 in 2023. And where we significantly declined, 43 questions, just 2 in 2023. And similar questions where we've stayed the same. And what those tables show is where we've got our most declined scores and our most improved scores. I will caveat that though, when you look and comparing our scores nationally, we still are performing really well. If we look at our colleagues from our ethnically diverse communities, I think the area for focus, when we compare ourselves nationally, we have better scores across the board, with the exception of discrimination. But when we compare ourselves, and similarly, when we compare ourselves nationally, we have best scores compared to the national scores in all areas on this table. But when we compare ourselves against our performance last year, we've decreased when we look at discrimination. And similarly for our colleagues who have reported to have a disability, we see good performance against the national scores, but when we're comparing in 2023 and our colleagues, we see a decline in our own performance. And that reflects on that table. And then regional results, so this is best scores in the region. So Northumbria had the best scores for all of the elements bar 1, which is we work flexibly. So that put us at the top. And when we do the analysis at a regional level, a national level, we had 2 best in scores, and our average score placed us tied 8th. So I think in next steps, it's absolutely looking at our RES and our DES data and looking at how we can improve, and I know Patrick's coming in to talk about that to the board today. Claire in particular has looked at the bank staff data for our RES colleagues, and there is a negative difference there, and she has a range of actions in place, so looking at having a check-in meeting with all staff from our ethnically diverse communities who are on the bank at 1 month in when they've been recruited, training the staff, so they're going to be doing the bank staff themselves, the bank team are going to be doing some inclusive cultures training, and also a welcome letter and support, looking at how they can improve support. And Patrick will be coming to the board to talk about the wider population of our RES and DES colleagues. In terms of our team, we're very much looking at leadership and management and our team and how can we support in terms of our intervention and our staff improvement, staff experience improvement programme, and we're just underway looking at developing a programme for managers and leaders about understanding data, how to focus on improving staff experience when you're a leader in a department at any level. I think obviously is the working flexibly, there's been a lot of work done. I just think the surveys is the timing is it hasn't been running along long enough in terms of some of the interventions that we've done in the trust. And then we've got the dashboards, so all of the dashboards for our subsidiaries are just being finished. We're going out to all the board meetings and the various governance meetings to talk to our boards and our business units and our subsidiaries about their actions going forward and discussing what they may look like for the year ahead.
Joe, thank you. That was really clear. Clearly, the findings on racial equality and disability equality are really important. But can we save our discussion for that to item 4.7, please? Other points, please.
So just a couple of quick things. Whether we are going to set up focus groups just in terms of not just on the res and des data, but actually some of the other actions that we might want to follow, to hear from staff around. Actually, we can then go back and say, you said we did, to really understand, for example, around the appraisals, what is it that they do, because everybody I've spoken to talk about the shift in the documentation, how it's so much better now, but it's not reflected in the scores. So I think we're missing something there. So I think we really need to understand a bit more depth behind some of those questions. And then my other point was just to ask whether any of the results are standardised for response rates. So we know that there's a huge variation. Some of the organisations on that list have relatively low response rates. So I think some of them was 37%, there was a 56%, and they yet still score highly, and how that's moderated.
We've contacted Pepper who run the survey, so we're just waiting to hear back from them. Yes, great. To understand that, and also the change to the 2 decimal points as well, which is a recent introduction, so we're quite interested to know the basis for that as well.
Because I don't think it is moderated at this point in time, but I think it's relevant, because I think the higher you climb up the response rate, you would suggest you're getting people that haven't responded before, which is great because we're getting people's views, but then the potential for decline in survey results.
And just to pick up on your point about talking to staff as well, Bijou, Kate and I have done a couple of visits to different departments, and we said it was such a great opportunity to talk to staff and just to have those informal conversations about what does this mean. So we're going to look at developing that into a programme where we just visit different departments, wards and teams, and have those conversations in a sort of informal, tell us about way, because it feels really, a great experience.
Okay.
Yeah, thank you. So just following up on Bijou's point, so at the PCC yesterday, the People and Culture Committee, we drew out a few of the key themes, so appraisals, flexibility, etc. So those will be the areas of focus for relevant business units, and then those will come back to PCC for us to see what are the actions and what's the impact of that. I think in terms of, well, put my other hat on, but NPC, I think it was expected this year. They've gone through a huge year of change, so it was expected. It's not an easy read, but there are obviously actions in place to support them.
I almost find it reassuring to see it, because we knew for NPC we took on a large number of new staff short notice at a time when they were under challenge. If we hadn't seen a drop in some of those performance measures, I'd just been questioning the figures themselves. So strangely, it's reassuring. Yeah.
I absolutely agree with that. Chair David Hedgecock preempted that before the results actually came out, which is necessary.
It's just, I think it's a point well made by Bijou about the staff, their appraisal process, because it is better than it's ever been, I think. It's more straightforward, direct, etc. So why are we not getting people to understand that? And I don't know, Joe, and you're maybe already on this, I just don't know, involving a group of them from each area just to participate in what is it that we're not getting back from the staff that I think we should do, because we're making the appraisal shorter. When we meet them, we're going through it very detailed and it's very self-explanatory, but at the end of the day we're not getting the results that we think that we need, and we know that it means a lot to our staff about their appraisal and what we think about and value them, the direction of travel that they're going in.
I think that's a really good idea. Marion, we've got our third Better Together session coming up in Ashington, and that would be a really good conversation table to say, actually, we've made these changes, this is what we see in the questions, help us to understand. So I think that would be a great idea.
Okay.
I think some of it's about your manager and your leader as well. So, and I think with the staff survey, some of the questions they're answering around other things, and I think if you have a great leader, a great manager and a good relationship, you're probably going to answer a number of the questions within the survey very differently. And I think, Joe, we should be exploring that within the appraisal conversation about support from a manager as well, because that's the relationship with the manager and how you feel valued will give a different score in that. Yeah.
Good. So, as we're used to, an excellent presentation from Joe and broadly positive findings as well. I must say I'm never quite satisfied when we come tied 8th nationally. I know I'm feeling you were higher than that last year. Just to remind me, Joe, 4th last year, so that doesn't feel entirely comfortable, although I know that the margins are extremely narrow. We've heard that there's a real focus both through people and culture, but more broadly on those areas where we're still not performing at the very top, and that's just what we should be doing. And we've heard the need to really kind of deep dive a bit in some of this to understand what is it that people actually mean when they say that they're not yet satisfied with something or other, and therefore that our responses might need to be quite refined and differentiated.
Can I just check, Joe? When we were 4th, was that within acute and community, or was that across? So this includes 2 children's to make it 8. So not that I'm being picky or anything.
Well, yeah,
that's at least 6. But then when you chuck in a response rates of 2 of those others, you've pushed it. But I'm just
okay. That sounds like a bit of self-justification. So I don't think we should allow ourselves, until we're the first, I don't think we should start only criticising the methodology. Well, actually, once we're the first, that's the time to stop questioning the methodology. Okay, I think we're receiving this with the assurance that we're really working hard on those areas where the scores are not yet at the level that we want them to be. And okay, let's note that there's maybe different ways of interpreting the national data. Does that satisfy you, Kingsley? Okay, and we recognise the individual circumstances, particularly within NPC, got every reason to think that the positivity will increase during the course of next year. Thank you very much indeed. On to Guardian of Safe Working Report. Mike, you're back with us. We see you 3 times a year, and it's always an unadulterated delight. And let's just see, particularly, it's a vacay report. The comparatives in particular, these 223 exception reports, it's more than last year, although it's less than 2 years ago, is that right? And is that just kind of random variation, do you think, or is there anything we should be detecting in this?
I think you've jumped me to
sorry.
reports, thank you. Hello everyone, we've got through winter since I was last here, so that's good. Things are looking pretty rosy, I think, from a safe working perspective, and hence it's a fairly boring report and presentation, I'm afraid. But you're absolutely right. We're going to be a bit above 2 years ago, because these are through to the middle of March, these figures, and we get about 20 so a month, so there'll be another 10 or so on top of that. It's less than a couple of years, 3-4 years ago. I think the 182 was an under. I don't really know why. We were a bit under with the 182. We tend to get about 20 a month, heading for about 240. But no real change to the pattern. We had a little spike in trauma and orthopaedics in Q3, and that was due to some issues with the rotors not quite matching the start times. Some work was done with the rotor teams, and that was sorted out, and thankfully hasn't continued into Q4. So we've seen that happen before in obs and gynae. When there's a rotor issue like that, it does spike up, which is reassuring in a way, because it gets picked up through the exception system, and then we can intervene. So that was quite nice to see, and we had a very prompt response from trauma and orthopaedics to get that sorted out, which was great. The majority of exception reports, the pattern has not changed in the last, since I've been in post. Majority are in medicine. It's our biggest area of work, really, and there's no current hotspots. There's always quite a few from elderly care, but some quarters it's higher than others, but overall quite a number from elderly care, but no massive spike. We did have some spikes there a couple of years ago that got resolved. Most of them are people staying late and picking up, getting the time back at a later time with time off in lieu. And we're not outlying in our exception report numbers. So I managed to get some regional data. Did I put it on as a slide? Yes, I did. So this is some figures that were collated by the regional chair of the Guardian Safe Working Group from fairly estimated figures that we gathered at the meeting and comparing to the number of resident doctors in each place. And you can see we're just under 1, which seems to be the norm. There's more in North Cumbria and South Tees. Gateshead aren't on there, and they have almost no exception reports at the moment. They've got a non-functioning exception report system. I'm not sure why they're not using Allocate. They don't seem to have a functioning system, and that was reported to us as a group by their guardian. I'm not quite sure why you'd want to tell everyone, because it's a bit of a failure, but they need to sort that out. But we look good in comparison. Going on to the postgraduate doctors, or resident doctors forum, I should be calling it now. We had poor attendance coming out of the pandemic, culminating in January 2023, where we had no resident doctors at one of our forums. Did quite a lot of work, and the numbers have picked up. For some reason 13 and 20 seem to be the two numbers. We probably undercount a bit, because some people, we do have numbers of people in rooms, and our register isn't as good as it might be, but we deliberately undercount rather than overcounting. And there's actually was some data I presented at the last report that we're favourable in numbers compared to regional counterparts when you look at numbers who attend compared to numbers of doctors working in each trust. We're still doing the drop-ins. I see quite a few of them at NSEC every other Tuesday lunchtime, and get some informal feedback. Sometimes that leads to issues. Little issue going on with the taxis at the moment. So we have some taxis for people who get fatigued, and someone is using it and we're not sure they should be. So Alison, the Safe Work Administrator, is getting very excited about her detective work to try and find out who's doing it, because they're not leaving their name with the taxis, and we don't think they are doing it when they're fatigued. So we're having to try and track that down, which is very exciting. But all in all, things are going well in that area as well. Rotas, nothing new to report. Our rotas have been fully compliant since 2020. There's still rota gaps. You can see the numbers in the report. It's par for the course. There's always going to be some gaps, and the rota coordinators do a good job with the teams to cover almost all of those gaps. We're still, through Gold Command, allowing ourselves a little bit of leeway on the rules, and until I hear otherwise, we're going to continue. We did do it through winter, and then summer seems to now be winter, and COVID's a while ago, but the pressures are there, so I think that does make a bit of a difference. There are some doctors who are able to pick up locum shifts in trust that takes a bit of pressure off the system, and I don't think it's unduly unsafe. So whilst you're good enough to let us do that, we'll continue to do that. And it was so boring. I thought Sir Alan might like this picture. There's Dan Byrne. He came to open Blythe Children's Outpatients late last year, and I got the chance to meet him. I don't do a clinic in Blythe. I have been there before. They invited me, and he was lovely, and I think I'm about the same height as Alexis McAllister, so he was marking when he scored, but I'm not that far, not much taller, so I could be marking. Look at the size, he's a monster. Anyway, that's him at Blythe Children's Outpatients, that's him in front of the Geordie Massive, having won the Carabao Cup. So,
thank you.
That's the take.
A helpful reminder of that great Saturday. Arsenal won 1-0.
Oh. Well, you shouldn't mention Arsenal in this company.
Enough.
2-0 and 2-0, I think.
Mike, thank you very much indeed. Questions, comments to add? The regional comparatives, you ended up saying we're kind of middle of the pack. We're middle of the pack, but we're twice as high as the 3 better performing trusts. And we've been at this level pretty constantly for ages and ages. Is there something we could do to actually be performing at the same level as the other trusts? I don't know, are you about to try and answer, Simon, or comment?
Well, I think exit reports, a bit like instant reporting, it's good that people do it. They feel able to say, yeah, it was a busy day, I didn't get home on time, and I'm going to exception report it. And actually, most of them, when you speak to them, wouldn't have done it, it'd be easy. It's just, they know it's the right thing to do, but they're not too alarmed about it. And it was averaging 1 exception report per doctor per year. So each doctor is going home late once a year. Now, I've just had a text conversation with Laura, who's really pleased that she did such a intelligible thing earlier, because she was in that building until 10:30 last night on call. You know, so our seniors, they're often going home a lot later than their anticipated time. So I would say I'm not sure I'm overly worried about that kind of number. What I do need to make sure, and Mike's really good at doing this, is making sure that we are having individual conversations, because it forces that. How was it? What happened? You know, were you okay? Could you hand that over? How do we recompense you? Just making sure, and certainly where we've got systems where the same ward is happening day after day, week after week, we've got to say, come on guys, what is going on here? But you're not wanting to play it down. I think we've got a system that works.
I know Jeremy's on, but I want to hear from Maria first, because I kind of want to get the tape from the practicing doctor as well.
Thank you.
I'm sorry.
Must have the key for CPR.
No, it's all right. I'm just wondering if it's a positive signal because there may be more of a culture of support to exception reports. So I see it as a positive, much in the same way that high level of DATIX reports doesn't mean that you have a safety problem. It means you have a learning from the issue. So we don't know what's going on in other organizations, but I would bet a significant portion of my salary that people here are supporting the exception report, and that's a good thing.
Thank you. That's helpful. Jeremy.
So I just think, you know, this is reporting how our rotas are run, and I think they are run pretty well. And we're a pretty well-staffed organisation and manage to get staff in the right places. We definitely do hear some other feedback about what the experience is on shifts, and I think that's probably something that is of more concern to us. But I mean, that does relate largely to what goes on inside a pressurised hospital.
Okay, I'm being told not to worry about it coming in and coming back.
I'll take a little bit of issue with it because it's not better. I think Simon's point's exactly right. It's a bit like DATIX is what's the right number?
Yeah.
And the right number is not necessarily the lowest or the highest.
Okay.
So we're not outlying, and you see on the graph the 2 spiky ones, they maybe have a problem. Gateshead, who aren't even on there, definitely have a problem.
Okay.
We're in the middle of the pack.
Okay.
Sorry, Alan.
Yeah, am I allowed a brief anecdote?
Go on, yeah. It's your last one.
I mean, last New Year's Eve, I went to the Queen Elizabeth Hospital with the 94-year-old aunt, having laid in, she laid at home for 4.5 hours before she got an ambulance. I met her at the hospital along with another friend, and by midnight, she'd not been, or about to midnight, she'd been seen. You know, there's this nice doctor walked in, my name is Toby, and he said to her, I'm very sorry, he said, it's 5 to midnight. He said, I can't do anything with you now. He said, because my shift ends at midnight and I'll have to go. And I mean, I personally was horrified by that. She was horrified. And he went. But she's actually very well looked after that. So there actually is an effect on patients when doctors walk out.
So some level of exceptions actually can be a sign of good practice and effective management in hospital. What about this issue about, that Mike raised about the flexibility in treatment of rotas and hoping that we continue to be flexible. I'm not sure I quite understand what's being asked of me, but does anybody got a view? Anybody that knows better than me?
I think we should carry on. I think it's a good thing. It allows the team to contribute back. It's essentially allowing them to work on extra shifts in order to support their colleagues and cover gaps. And I think on a voluntary basis, in a managed way, that was a change that occurred in COVID that was a good thing.
I think I probably didn't explain it properly. It was a change in COVID under a lot of pressure.
Yeah.
And there's certainly no evidence that we've got since then of anyone having their arms twisted to cover shifts. This is a voluntary thing for doctors who want to do a bit of extra work, and it's helping us. They can do it elsewhere, I suppose, but they don't really do it with us.
Thank you. I've got Marion and Ruth.
Yes, well, just the same as Jeremy said, it's been really, really helpful, thank you. It's been so flexible, and it was very rigid before, and I think we do appreciate it.
Ruth?
I was just going to bring it back to audit and Mike's taxi point. So we have got taxis on the audit list for this year for that very reason, which is we are spending a lot of money on things that we're then not able to trace back to people. So I know we made it as a joking point, but we have got a real issue and we have got to address this audit report.
Okay, thank you. Paul?
And just to emphasise that point, there was a working party looking at tax use and reinforcing controls, etc. So I've just emailed that too.
It's, I mean, on the taxi point, our bit of taxis is not a lot of use, and it's to stop us having to have a room for them to sleep in afterwards. So it's cost effective, and it really isn't misused very much at all. It's just, it was quite exciting for us. I haven't found the person yet. We might find them.
Okay. Then are we, I think we're ready to receive this report. We've probed to see whether being in the middle of the pack rather than at the bottom, it was a sign of shame for us or not, and I think we've received assurance that actually we're at the right place. There isn't an ideal number, there's a number that's right for the trust, and I think we've heard a lot of commentary from people that know much better than me that we're roughly the right place. We've heard that the flexibility that's currently being deployed is of value, and therefore we shouldn't seek to overturn that. And I think on that basis, we're ready to receive the report and thank Mike. Yeah, good to go. Thank you very much indeed, Mike. Shame about the last slide.
Mike,
Patient and staff stories. How nice to get these reports on the Lung Oncology virtual ward. Last time round we had a harrowing patient experience report, so it's nice for us to do a little bit of mix and match, and every now and again have one that's so complimentary. So Joe, just bring this to life and then we can take comments.
Just before I start, I'm not bitter and not twisted, but I will get a slide of Mopsala in my presentation as a written variation, just for printing notes.
Only WASP can.
So this was my absolute pleasure to bring this to the board today, because it's part of a report that the team did for the Lung Oncology Virtual Ward team. So it consisted of 8 interviews of members of the team who deliver on the virtual ward. I thought it was very timely today. I didn't realise community services would be doing their update when we originally planned this. So it brings the virtual ward aspect of their presentation to life. And then it's reflected by a family member. So if you forgive me, I've just lifted one section of the family member because I think it demonstrates everything that the staff and the family member says. We were always treated well. Everyone was very supportive, very kind, very accessible, everything you could want. Even if we didn't ring them, they would ring us, sometimes up to 3 times a week. Like I've already said, they gave us invaluable support. The communication was always spot on. They took the time to explain every little thing they were doing or planning. We were always involved in any decisions, and my husband was always treated as an individual. The care we received was extremely patient-centred. They were just excellent. Their manner, attitude, everything. They were just so nice and understanding, we couldn't fault them. And I think what I found when I was writing this report is I started with the staff, and I talked about and overwhelmingly we've just talked about staff experience. The staff, through their interviews, demonstrated they were absolutely invested in this service and what it meant to them. They felt that they have an ability to feel reassured that their that their patients are being looked after when they're away from hospital. The responsiveness of this service gave them reassurance as clinicians, and the improved communication between them all as a multidisciplinary team. And when I then started to use the family member interview, I was able to match up every aspect of what they said, the experience of their patient they felt. This lady absolutely described line by line, so I could match it up. So I think it's an absolutely excellent piece of work. Just one area for improvement that the family members talked about was that information when coming from a ward, understanding from an inpatient ward, understanding what a virtual ward is as you go on to one. And that was the only area for improvement that I could find throughout the report. And if anyone would like to see the full report, I'm more than happy to share.
That's great, and it sounds like Jeanette, Cherry and Helen are quite a power in the how you're doing that. Questions, comments, reflections? Simon?
So it's really, really powerful, and everything people do is fantastic. I think it's just a note of caution about that word virtual ward. We've always saying about hospital at home thing, but that technical definition of virtual ward is you would be in a hospital bed, but we provide you a service at home that allows you to leave hospital. For most of these patients, that isn't the case, and so it's more aligned with what we think of as community care and the palliative care services, etc. So there's just we absolutely need to support this service. It's doing some fantastic things. It's a really powerful story, but it isn't actually a virtual ward, and you know, we've got to deal with that as a service about how we talk about all of these things, and therefore understand the nuances, because the person involved in mind what it's called, but how we handle it and how we get paid for it are different things.
That's actually a really helpful clarification for me, I think. Thank you. Anybody else other than we can just be really proud of our staff that have been delivering this service? Thank you. Then what about the patient experience update, Joe? I know this has gone through several iterations in different places, so again, we can be quite brief on this.
Yeah, just a couple of headlines. So I think in terms of our overall performance, when we have our external measurement, we continue to see consistent, strong performance when patients provide us with a rating of care. So across November, December and January for outpatients, day case, inpatients, we saw that consistency around the 60% mark of patients rating their care as excellent. I think when we look at areas for improvement, it's particularly around the way for admission at the discharge process, and particularly on this set of data was around hydration and drinking, which we're doing a deep dive analysis to try and understand that better at ward level. Emergency care, we continue to be in the top 20%. Our areas for improvement continue to be waiting, which we're monitoring closely through our real-time report. So we see that on a month-by-month, twice-a-month basis. And some of the other areas are around the information that our patients receive while they're there, and pain and the reason for attending the department, how that was dealt with, and feeling that was dealt with appropriately.
Oh, we discussed that in some depth last night, so we don't need to repeat that discussion.
Our community service business unit, patient experience is extremely positive. So overall, most people would rate an overall satisfaction rate of 93.93%. The areas that are particularly positive are around the relational aspects of care, so the emotional support, the respect for values, beliefs, and the quality of the staff and the relationships that our patients have with them. When we look at that smaller proportion of reported negative care, it tends to be around the more transactional, which is processes and systems, and in particular access to the service and the wait. And I think I'd leave that there for today, Chair.
Thank you, that's really clear. Who wants to raise any questions? We have such a luxury of having so much data and information, and as a consequence, so many opportunities to chew over it and respond outside board. But it's good just to bring it together in the way that you've just done. Thank you very much indeed. Let's note that, and let's go on to the patient charter that I described to governors last night as perhaps the most important document that we have produced in this trust since I started. So, Joe, how's it going? Oh, sorry, Jeremy, how's it going?
My journey?
It's up to you two. It's entirely up to you two. I've got it on my agenda as Jeremy, but
She's done.
We're fighting over this because we're so enthusiastic about it.
Joe's done all.
She'd better do it, hasn't she?
So by way of background, the patient charter has been co-designed and produced through a whole range of engagement processes, both with our lay representatives, the VCS, our own staff and the wider community, and it's very much about looking at the things that matter to our patients and their families and our carers when we're having the conversations and we're preparing for appointments and what happens after our appointments. So to date, so obviously with the charter is now signed off, and we have a task and finish group, and that task and finish group is overseeing the actions that are required, because what we want to do is we want it to become just business as usual for Northumbria, so it's part of our day-to-day business and integrated in every bit of the work that we do, the service we provide in a meaningful way. So key to that is communication, the communication activities. So since it's been signed off, we've been doing a whole host of soft approaches, so just talking about it, any events, etc. But now we're working with Jane Faulkner from the comms department, and we've got a whole range of comms resources. We're about to launch a staff page, portal page, a public-facing web page, and we've developed an easy read version, which we're particularly proud of. That the charter's very much in line with accessible information. That is one of the principles in there. So we will go into our hard launch in the next month. Skip over that one. So we did I won't let it play, so it underpins the lifelong care strategy that was talked about last night in Governors. So we did one of their podcasts. I did tell everyone, Judith is one of our lay reps, were really distraught because we didn't realise we were going to be filmed. And Judith said she's never going to speak to me again. But I think it was a great opportunity for us to really talk about what the charter is, how it's being developed, and what our vision and our hopes are for that charter. We very much see, I said this to the governors last night, we very much see it for a driver for change and a driver for improvement in terms of the experience of our patients and their families. So what we want to do is we want to do a baseline measurement. We want to know where do we sit currently when we measure ourselves against those 10 principles. So we have a baseline survey that's been developed by the Task and Finish group. We've read engage tested it. We're testing it first of all with our early arthritis clinic with Liz Coulson and the team, and then we will follow that on with a full measurement across all patients that attended for an outpatient appointment in February 2025. And then what we will do is we'll look at that and say, what have we learned? Where do we improve? And actually, how do we then transpose some of these questions into our more established programme, so we've got that ongoing measurement of the charter. And I'm really excited to say that with Charlotte Routh, we're going to, and in NSET, we're going to look at our real-time inpatient programme around the pathway measurement. We're going to look at piloting that, and we're going to align it with the charter principles as well. So we've got lots and lots of pilot and test work going on to look at how do we then integrate that into our established programme. A big part of the work is, as I said before, is that integration of the charter. So we don't want it just to be a comms exercise to say this is the charter, and we want it to seep into our DNA and to be part of what we do. So we're looking at what are the opportunities, what's the art of the possible, and in our meeting yesterday we came up with a whole list of things that we thought actually we need to go and talk to people. So preceptorship training, our medical training, our induction, a whole host of things that we'll go and talk to the key people to say how can we integrate the charter. So far we've looked at working with our policy improvement team. It's part of that. We've developed a self-assessment tool for our policy panel, and that's been tested now with one team, and they'll give us some feedback on how that felt for them when they're self-assessing themselves against the charter and how they're performing. Also, we're looking at how we can work very closely in terms of quality improvement and ensure that it's included within the policy improvement process when teams are leading on particular pieces of work. And if you needed a reminder, we've just included the charter there. So I don't know about Jeremy, but I feel, particularly after yesterday's meeting, it just feels like the whole thing's coming to life now, and we're really starting to get into the doing after spending a lot of time developing.
Jeremy?
Joe, thanks very much, and thanks for all the enthusiasm that you give to this. But I think this is something that is about changing the work, some of the cultures within the organisation and some of the ways that we work. And I was at a quality panel just the other week in community services, and it was an absolute gimme for them. It actually really fitted completely into the way that they're working, but it won't be the same in other teams and other services. And along the way, because this is about major organisational change, it's a highly complicated process. So it's really important that the Charter isn't that change, the Charter is just the principles of where we're going. And if we're not brave enough to write down where we want to go, we'll never ever get there. But there will be some barriers and some tricky bits to get over in between, not least some of the systems that you have to have in order to operationalise, I don't know, 250,000 outpatient appointments a year.
Yeah. Great. So we need to be a bit patient. We won't achieve all 10 overnight, but having it out and having a clear plan for rolling out appears to be entirely positive. Any questions or comments? No. Thank you. More power to your elbow. Let's move on. Patrick, welcome. Equity inclusion update. We were looking at the staff survey report a bit earlier and feeling some discomfort with what we saw in the resident days data. Some of them moving slightly in the wrong direction, not enormously, but slightly in the wrong direction. And we saved all our critical comments and questions until you came.
So pleased. All right, hi everybody, nice to see you. So, although this kind of covers all the equity and inclusion information that we present, usually the kind of focus on the resident data I think is really important in this respect. Now, I think if you look at it in comparison to other trusts nationally and regionally, we perform pretty well. But the one thing that really exercises, isn't it, is some of the gaps between the experience of specific groups of staff compared to the overall staff body. So that's kind of all I'll focus on really. So just to give you a little bit of background of the data that we did gather and some of the things we thought were quite important. The interesting thing is we've now got nearer 10% of our staff body are from a Black, Asian, ethnic minority background, so that's increasing regularly. Now you'll notice from one of the slides on here that one of the issues for us, for both Res and DES, are the difference between shortlisting to recruitment rates for BME and for disabled staff. So they've both gone up. Res has gone up higher than for DES. That's only been a very slight increase, not significant, but that's something that's been coming down in other areas as well. So that's an area that we do need to focus our performance on. The good thing in terms of the Res is that some of the harassment, bullying and abuse scores have come down significantly since 2019. There's been a steady decline in those, and in at least one area it's more or less equivalent to what it is for white staff. But again, there's still that gap that's persistent between the experience of BME staff and white staff as well. So we'll be looking at that as a kind of an area for action. Again, the appointment from shortlisting issue is not just something that's specific to our trust. That's something that's been very significant across a lot of trusts, even though we've had a big increase. One thing that has become apparent is the percentage of staff applying with a BME background for posts has risen by thousands of percent across the board. So that's a national trend. It's not just something to do with what we are doing here. So we need to understand that better. We suspect it might be something to do with the use of artificial intelligence to put in applications, which means you would be automatically shortlisted. So again, I would be more worried about that if it was only our trust that was an outlier in that respect, but it's not. In terms of the Disability Equality Standard report, again, if we looked at ourselves compared to other organisations, we don't do too badly, but we do have some very, very interesting areas that we need to kind of focus on. Our declaration rates have risen steadily, but very slowly since 2019 when we started measuring, so it's up at around about 5.5% now. But when you look at the national staff survey results and the local survey results that kind of Joe's presented, we're getting up to about 28-29% of staff saying they've got a long-term condition or disability that impacts on their ability to provide good service. So that's interesting. That's also, I guess, in the case for other organisations as well, because the rates are more or less similar in our regional counterparts as well. We know in the local population there's a far higher proportion of staff that have got not staff, people who've got disabilities, and we recruit locally by and large. Again, harassment, bullying and abuse rates are down compared to previous years, but they still remain persistently higher than they are for non-disabled staff, and that's a real concern. Largely that's the bits that we're most concerned about, I guess, are kind of where that's staff who are involved in those harassment, bullying and abuse scores. And the other thing that's of concern, I guess, is the reporting rates. They're around about 57%, and we'd like them to be a lot higher. Interestingly, it's 57% across the board, so it's not just disabled staff, it's staff who are non-disabled who've got the same percentage rate as well. The other thing that was an area of concern were the fact that people didn't feel valued. Even though that score had gone up compared to previous years, it was really significantly lower for disabled staff than it was for non-disabled staff. And we didn't see that.
Slide on, Patrick, so that the slide's keeping with your...
Yeah, okay. So again, representation is pretty good apart from at board level, and that's an area that we need to focus on. For BME staff, the distribution throughout the organisation was fairly good. It was fairly even. It was what was representative of the workforce in general, so we had less concerns about that. Engagement rates, as Joe will have said to you, have fallen slightly for everybody, and for BME and disabled staff that's a similar picture, but it's not a significant difference between all staff and disabled staff and other staff as well. So again, in terms of harassment, bullying and abuse, these are the scores by patient families, by line managers and by colleagues, so all of them are down compared to previous years, but again they're still higher, and some of them significantly higher, so the line managers' HBA scores are much higher, where we talk about managers 10% to 6%. In terms of career progression and people feeling like we offer equal opportunities, those scores were fairly good compared to national rates, but they were significantly lower for disabled staff than they were for non-disabled staff. Fairly similar for BME staff than they were for non-BME staff as well. And the other thing that was an area of concern was people feeling that they came into work even when they were ill and poorly, so that presenteeism score was quite significant. Again, people feeling valued was better than previous years, but again there's that 10% gap between disabled staff and non-disabled staff, so there's something that's not being communicated about people feeling valued at work. We scored really well around reasonable adjustments. That was one of the highest scores nationally. So again, it's something that we need to kind of keep an eye on, because that kind of all links into the flexible working arrangements I think that we make, so disabled staff feel like we do make reasonable adjustments. And again, board membership was proportionate executive level. And that might be just people not reporting disability, that might be in common with what we see with all of our staff. So in terms of we get a national benchmarking report back from NHS England, and the areas they've identified for actions for us are around the appointment from shortlisting for both RES and for DES, that reporting rate for people who are disabled, and the pressure to attend work when sick. So that's the kind of background. I can tell you we've already started taking actions, as you would expect, around kind of how we address some of those issues. There's something around being able to triangulate some of the data that we do hold around recruitment in particular. So we've got a pilot that's just finished now, and it's in the evaluation process of equity and inclusion reps on recruitment panels, and if that's seen to be effective, we'll kind of implement that across the board as far as we can. Recruited some network group members from both the BME network and from the disabled network and the autism network, the neurodiverse network, to look at kind of contributing to the action plans for the next year. And I think one of the things we might do is look at rolling out a third phase of the It's Not OK campaign, which is about looking at bullying and abuse and harassment. I think there's a lot of stuff that maybe we don't do quite as well as we could in terms of sharing information and data across freedom to speak up, staff experience, learning and development team, and kind of people taking opportunities for development. So that's an area I think that we will look at. We start looking at, we've already got data around disability and race pay gaps, which is pretty good news, and that's kind of it's reflecting what's coming out of the surveys, isn't it, really? So, kind of disabled staff don't fare as well as non-disabled staff, but BME staff seem to be doing better overall than non-BME staff, which is interesting. We're rolling out, we developed an inclusive cultures offer with the experience team, working with some wards that had quite an influx of internationally educated staff. And that's now part of our kind of consistent offer to staff. We'll do that on a quarterly basis. We've done that with some of our HR colleagues. We've done that with some of the wards. And we'll offer that on a kind of quarterly basis so that people can access that, as well as doing kind of bespoke training with that as well. And we already do that with the preceptors, with the senior clinical leads programme, and it'll just become a kind of a standard part of our offer. We make sure it kind of aligns with induction and other kind of training programmes that are around that. Okay.
Patrick, thank you.
Okay.
Really helpful, very clear presentation. Who's got questions or comments? Kate, start off.
Thank you, and thank you, Patrick. I think the first thing to say is some of the results a number of the results here are just unacceptable from a trust perspective. So I know there's lots of work going on, but I think in a number of forums this week we've discussed our staff networks, and I think we need to get back to face-to-face focus groups, asking the people who are filling this in what their issues are. So I think it'd be really helpful as an action, I think, that we board see some of those results back as to what people are saying and what they want us to do about it, because I think we've had reports like this where the results have been pretty similar and we've not made real inroads into it, and I think we need to shift on that, would be my view. The other bits for me around, Patrick mentioned about the appointment to shortlisting. There is a discussion around introducing the resident labour market test back, and there's been some changes to immigration which may affect some of those results as well.
Can you just explain that a bit more?
So the resident labour market test is where you have to satisfy that you can't appoint from within your local community environment before you accept an overseas application. So yeah, I just wanted to mention about the networks. We need to strengthen that network. We need to have the discussions with the people that are filling this in.
I think to be fair, it goes beyond the networks as well, because that's a limited number of people who attend,
sure,
and I think there's a whole staff body that maybe don't ever get involved in networks, who'd have some quite interesting things to say,
no, you're right.
Particularly clinical staff.
Networks is important for this and other areas, and with the notary we were talking yesterday about, we haven't been hearing quite so much about the network coordination of late, and we've kind of let lie a process that we used to have whereby board members were kind of linked to networks. This is something that needs to be revisited.
It is. We need to do that. Yeah.
Okay. Can we ask for that for executives to have?
Yeah,
give a bit
we've
of
got a
thought
list
to that?
already.
Yeah, but I'm not
We
sure
just
how.
need to share that.
Yeah. Brilliant.
Thank you, and thank you for the report. If I may, I just wanted to ask for some clarity, because I might have misheard something that you said earlier on about recruitment, where it sounded as if people from ethnically minoritized groups were as likely to be shortlisted. But did I miss
less likely.
Less likely to shortlisted. Is there any narrative around the causality of that? And I don't know if that's come out in what you do. So it's two questions I should have said to start with. Around the causality of that, and then down beyond the shortlisting process. The other question or comment really was around working when sick. And I don't know if the way that the questions are phrased teases out that long-term debility that comes with chronic conditions. So somebody who has a disability, for example, whether overt or not stated, has a long-term debility. So they are coming to work while sick. They're not as fit as somebody else who doesn't have that condition, and how that is interrogated in the way the question is posed. Thank you.
No, it's okay.
Patrick, can I just pick up the appointment? Because I think we just need to clarify that. So BME staff, they are being shortlisted, and that you can see on that graph that is rising. It's the shortlisting to appointments. So once they're shortlisted, they're not being appointed.
That's what I thought.
Yes, that's it.
Okay, and the working while sick?
And the working while sick, again, if you look at kind of who declares disability on our ESR system, it's low compared to the numbers of people who are telling us in the survey. So there's something we need to do about kind of assuring people that kind of being part of that HR process is not a punitive thing. So I think there's still that perception, even though we made a massive effort, I think, to make that a kind of a wellness approach rather than a kind of sickness one. So I think, again, in working with the network groups, I think we'll get a better understanding of kind of why people feel that way and why that's kind of coming out of the reports. I couldn't tell you the reasons why that's the case, but if people are feeling that, then, you know, I don't know how that's borne out.
Okay.
Thank you. Just following up on that point, you know, as someone who is disabled, it's really difficult to interpret that because you feel that it's an awful label to have, and you want to have pride in that you can come to work. So I think you have to be very careful how you interpret that. I think also some of the appeals that I've been chairing, some of the things that are coming up are very much about cultural differences. So you don't have to come from abroad to be culturally different, and it's how we make sure that induction process is inclusive enough so that they're understanding what the culture of this organisation is.
Beautiful stuff.
Yeah, no, I think you're absolutely right. So when we're doing the cultural training, it's not about race, it's not about ethnicity, it's about all differences that occur within our workforce. It could be LGBT issues, people who've got hearing or sensory impairments, you know, it could be anything, men and women.
Good, okay. Any more on this? We're not yet satisfied with the figures, right? We're keen for the further work to be done. We're hearing that there's further work to be done. I know people in culture are keeping a close eye on this, and I think as non-execs we want to hear a little bit more about how the staff networks in general are going, and to enable us to revisit our function as board members in relation to networks. But are we happy to thank Patrick and receive this report? Thank you very much indeed.
You're welcome. Just one more thing, I think with the local surveys, what's been really reassuring is the percentages and the numbers of staff who are willing to tell us what's going on with them, which is why the figures for disabled staff is so much higher in there as well. That's a good sign, I think, that people are willing to do.
Thank you, Patrick.
You're welcome.
And we're on now to board walkabouts. We're running about 5 minutes behind, so I'm just encouraging colleagues to be fairly brief. We've got 3 board walkabout reports, and the first one's from Richard with the Annick Theatre. You had a great time.
Yeah, you and I saw it within a few days of each other, so I think it's fair to say it's a fantastic facility run by a wonderful team of people. They're not show bands, that team, so it's really good to see that we've delivered for them and for North Northumberland with what we've done in Annick. I was just going to highlight 3 things. First of all, when we close theatres for refurbishments, we know it's a very unsettling experience. But the experience of Annick has shown that the period they spent at One Spec was very enriching, both for them but actually for the hosts. And I think it'll be interesting to see if we get the same feedback from the Hexham team after we finish the work there. Second comment is that having created this fantastic facility, we need to get it used. And you know, it's great having 2 lists a day, it can do 4, and we should be doing that every day of the week. And the final comment, just to stress the importance for patient experience and toast. And although we are nervous about unsupervised toasters, don't throw the baby out with the bathwater.
That's a really neat summary, thank you. Anybody want to make, yes, Bridget?
Just to add on the toast thing, I think there's some kind of campaign that I've been watching happen on Facebook about reintroduction of unsafe toasters.
We are trialling the switches on the toasters, so watch this space.
Okay, so key conclusion, safe toast campaign. Okay, we're going to try that, right? Phil, yes.
How was the car parking?
8 o'clock in the morning, it was superb.
And last time I was there, the machines were working, so something's happened. Yeah. Good, thank you. Not quite so much fun you had, Katie, at the Lead Employment Trust at Stella House.
No, Yeah, it was an interesting visit, and for Phil, parking was awful. So
It's terrible there.
Yeah, it was really awful. Just the atmosphere. So the facilities that the team have are good, but where they're sat in that office in between ICB and NHS England, it was like I said, it was like Mary Celeste, just a quiet office. Nobody there, nothing happening. So I wouldn't be comfortable going there to work every day. They did come up with concerns about the volume of work that they're doing, so with training doctors, cultural differences, back to what we were saying earlier on, differences, and that means that their capacity to manage this on time is difficult. There's also still concerns within the team about their sickness and behaviour, so again it's an area that we need to really think through, and how they feel engaged with the trust. I know we're doing a lot to make sure they feel part of the trust, but how we can advance that even further. I just think it didn't feel like part of the trust.
Katie, yes, Jeremy.
I was going to ask you,
Yeah.
is HEE still there? Because that was the original idea of them, because it is an odd
That was the
location.
reason why they're co-located, and I've challenged them because they only have to be in the office 40% of the time. So that argument is flawed, really. So when Katie and I went, we've got all the Leading Employer Trust employees, we've got ICB, there wasn't one person on a desk. And then you've got NHS England around the corner with a couple of people in. And I think Katie's absolutely right, it was poor engagement. And I think Lindsay, from a technical perspective for the LET, she's run the LET for a long time, she really understands it, but there was just not this staff engagement or a buzz around the individuals working there.
I know that there's the requirement that this is not hosted in-house by Northumbria to make sure it's seen as a regional bit.
No.
But this arrangement, it doesn't feel like it's working.
In the contract it says that it's a preference they're co-located with NHS England, but I think there's more of an argument now from being to bring them into with my team.
Are we not going through some consultation process then with the PROs?
We are, yeah. That's only a couple of them though.
Yeah, but it should, I mean that should, and there won't be an NHS England.
No.
It's an awful bill that.
We should.
Okay, can we ask for, I mean, it sounds like further thought has already been given, and that's great. Can we just ask for a report back in due course with some options, what we can do? I don't think, if we receive a report like this with this level of dissatisfaction, we can't just say, not let it go back. So, thank you, Katie, for that, and let's move on. Your next one was a bit happier at once,
Yeah, an awful lot happier. It was lovely. I think Kate and I left feeling energised, we really did. I think some key points, there are about roughly 300 to 400 management referrals a month. It's taken 7 weeks for occupational health to get through those. A lot of the referrals aren't really occupational health relevant, so again it's going back to managers being able to, leaders being able to ensure they only send through to occupational health what is relevant. The gym facilities were just, I hate gyms and I've been with that. I mean, it was just brilliant, and how they're focusing not on us all being fit, but our well-being, and some of the brilliant stories that were coming out about how it's supporting staff, getting them back to work, helping them externally in their personal relationships. That was great. So Kate and I were suggesting the next board meeting we'll be at the gym, see how it works. But it was a lovely visit and such a strong team.
That's great. Any comments?
Yeah, I think for me, yeah, well, it was just, we need to encourage more people to go to those gyms. So it was quiet, and I think there's capacity, and there's free personal training sessions, there's lots of capacity there. And, you know, Paul and I have talked to get free personal training sessions. You know, that's very expensive outside of the trust, so we just need to do a little bit of looking at that.
Yeah.
People might use it more if they pay and understand, you know, so we'll have a look at that.
Great, thank you. Colleagues, my apologies, we are running a few minutes late, so I'm going to eat a little bit into your lunch, I apologise for that. But we're into now the items for escalation from board committees, which means, of course, all these have been properly chewed over, so I am asking for reports simply by exception. The first is the nursing and midwifery staffing and assurance report. Aaron?
I don't think really, Chair, there's anything to say. People will have read the papers, and it's just been a very difficult month up in the month of February, because of the acuity and also the volume. Staff, as always, did a cracking job, and I don't think there's anything else.
We had the Channel 4 TV programme about fill rates.
Yep, so that came about, and actually it was probably, it was comparing apples and pears, because we weren't all on the same level of data. But what happened there was they particularly looked at the one-spec fill rates, and the one-spec was particularly Ward 10, which is one of the orthopaedic wards. And on that particular day, it was a very quiet day because we managed to get a lot of patients away home. And so we'd actually moved a member of staff to another area which needed it more. And that obviously got the rate down.
A really sensible, pragmatic step, which is not caught up by sensational journalism.
And that is absolutely what happened. And we did obviously investigate it when it came out, and a response was given. But you know, it's always good to get an opportunity to speak to these people, and we weren't afforded that, unfortunately. And I think our comms team are excellent at doing that, but we weren't afforded it this time.
And for the record, since the programme was saying that everybody's covering up on the data, the fact that we see the data very regularly and publicly is a bit irritating.
Yeah. And there hasn't been anything back from that programme from anyone, and nobody's come to me, I don't think, usually.
Good, thank you. Anything else coming out of that report from Marion? Allied health professionals with
Yes.
staffing insurance?
Just one thing I wanted to mention, and I always mention this particularly for Margaret because she's always very keen, and that just to look at our fill rates with our EHPs, because they're equally as important than our nursing and midwifery staff. And I'm very pleased to see that the vacancies have come down, and also staff sickness has come down, and that's all due to the teams all working together. So that's all I'd like to see with that. Thank you.
Okay, good. Any points arising? Learning from deaths, pretty straightforward this time, I think.
Yeah, we discussed it very thoroughly.
Anything to raise? Did anything come up at SQI that you need to be highlighting from that? No, I don't think so. Corporate safety and quality, risks?
Yes, so BG's already alluded to the performance numbers in a chief executive report. Just to say that at FIP there was concern that we haven't plateaued or gone deteriorating in some of the measures, so we'll keep a close eye on that in March, and we'll come back in April to make sure that actually the plans we'll put in place and mitigation around some of the deterioration of performance are actually working.
Yes, it's unusual to find 7 of the 12 standards not met. I can't remember that in my time, so the middle of March will be looking different. Any points raised? Then Paul, the corporate finance report.
On target to achieve all objectives.
Very satisfyingly dull, wasn't it, the finance report? That's what we like to see at this point. Okay. Anything more? Then we're into the any other business. We've got the agenda for the next meeting. I'm going to take as read. We've got the review of the meetings. Is it okay apart from it run on? We will have run on about 5 minutes. Any questions, comments about the meeting? Good. We haven't got any questions from the public, but we've got something from us, and it's back to Marion to kick off. For Alan.
Yes, so Alan, you weren't actually at SQ&I last week because you were on your holidays, but this was actually shared with SQ&I as well, but I wanted to share it with the public board too. So we obviously couldn't close our meeting with SQ&I or our meeting today without acknowledging the massive contribution that you've made to the various committees you've been on, to SQI particularly, but to the Trust as a whole. I think your absolute unwavering desire and drive to ensure everything is done properly is second to none. I think you're a national influencer. I think you've got very high standards, but you're also approachable, helpful, and you always know somebody to signpost us to if you can't answer the questions, and that's actually a very rare occurrence. You're a critical friend. You've been particularly helpful to me in my role and with the NMAPS board. I think helpfully married to a nurse, I think that's probably helped. But also, I think you're very interesting and you're very interested in everything. And you've also got an opinion about just about everything. And I think you've got an encyclopedic encyclopedic knowledge, not only of the clinical things, but non-clinical. So tourism abroad, North Northumberland tourism, particularly around Embleton, I think running, I think archaeology from Berwick, loads of these things, which just makes you the person that you are. You're quirky and you're fun. You've been a great chair of SQI, and thank you for that, but also for everything that you've done for us here. You will be missed by us all. So thank you, Alan, for everything that you've done over many years, and we wish you a very long and happy retirement, along with a lot of safe travels. And I just must add one thing, because Chris Platten will see you at the football, and he'll keep you updated, and you can exchange things so that it comes back to us, so that we keep in touch. Thank you.
She's 10 rows behind me.
Thank you.
Yeah, so
I know.
Mine's very quick, don't worry. So Alan, for those that don't know, joined us in 2018, so saw us through a tricky period in terms of COVID in particular, and then obviously, as Marian's just alluded to, as S&Q chair, who he did a bit of a double act with Moira, for those of you who remember, who he did insist on calling Marian all the time. And then you've helped us embed our move from safety, both in terms of the whole safety panel process, but then our transition to PSA as well. I think we've always enjoyed your challenge. That's been very clear through S&Q. But I think the other bit that doesn't always get shown overtly is that you've always wanted not only what's best for the trust, but also for the staff. And I would have to say, in particular for the execs, you're somebody who's always looked out for the execs and their own well-being as well, which I think all around the table here we do greatly appreciate. And then for me, my personal thanks, as you've helped me transition from my old role into this role, and I really appreciate that. And clearly it would be wrong of me not to mention your love of grapes, and I'm not sure whether that's grapes in general or my grapes all the time. But I hope you have plenty of time now to sit and eat grapes. And thank you.